Welcome, everybody. Today we have two presentations from Dr. Alice Bullas and Nik Kudiersky. The first presentation is titled 3D Anthropometry and ISAK, which is the International Society for the Advancement of Anthropometry. And we'll proceed with the presentations and followed by some questions, both from here and online. If you have any questions, also you can drop it on the chat. So I would like to invite Alice to start the presentation. Share the screen.
Hello, everybody. All the cameras down there. I'm going to move that. There you go. That's a little bit better. Slightly less unflattering angle. Lovely. Hopefully you all can see that. Is that sharing for you guys? Any thumbs up? Any yeses?
Yep, Alice can see that.
Thanks, Girish. So, hello everybody, I'm Dr. Alice Bullas. I'm a researcher in sports engineering based out at the AWRC, but based within SPARC. And I specialise in 3D, well, in body measurement. That can be 3D, it can be manual, but mainly external form body measurement of shape and size. And I'm here today to talk about a conference that I went to earlier on in the year, which is the ISAK. So, as the theme said, the International Society for the Advancement of Anthropometry's biannual conference. The society itself governs or provides standards as to how we might manually acquire body measurements from the external form of the body, and they provide training accreditation in line with those standards. The reason for this and the reason it exists, like all standards, is to make sure that practice across the globe is universal. So it shouldn't matter if you are taking somebody's height, weight, waist girth, ankle girth, calf girth, shoulder breadth, any external body measurement here or in Mexico or in Chile or in the US, they will all be following the same standards so that they are comparable. And if you're tracking progress, it doesn't matter who's taking these measures, they are in theory reliable because they should be accredited and following standards. So the conference itself focuses around all types of body measurement methods, applications of measurement, and kind of everything. Quite a broad conference really in both application but also in standards structure. And so at the conference, I went with four intentions. 5, although one's not bullet pointed properly, sorry. Oral keynote, so I was invited to become, well, I asked to host a roundtable to discuss body measurements, and they couldn't accommodate roundtables, so they put me forward as a keynote speaker. I also presented some research in an oral presentation from my PhD, as well as a post presentation from my PhD. But the additional intentions were to network and influence the society. So I suppose this is probably one of the first conferences I've been to where I have gone with a very tactical agenda as to what I wanted to achieve with regards to self-promotion, but also with regards to my future intentions in research and where I want to position myself globally and trying to work towards that strategy. So the first thing I presented was all about standardization in body measurement. This was the keynote. And what this reflected upon was the use of 3D body scanning, or thereby the absence of 3D body measurement within ISAK, and how the lessons that I've learned through various opportunities that I've taken on, such as the ICURE travel grant that I did at the end of 2019, taking off the learnings that I've kind of come to and presenting that to the ISAK community to take on board and explore how we can incorporate those learnings into the standards that the society generate. So I went forward with asks, I suppose, of ISAK on how we can go forward, how we can update the manual measurements that ISAK provide. So I should say ISAK is solely manual at the moment. And really kind of put it forward to the community that this is where I want to go and this is where I'm prepared to take ISAK to. The next bit was to look at research. So this was to demonstrate how measuring the body slightly differently, we can identify changes that go otherwise unnoticed. So this is measuring circumference along somebody's leg. This point, this middle point here, or on the screen, here represents the knee, so tracing down from the upper thigh down to the knee and then back down to the calf. And you can see that there is segments of change that we wouldn't necessarily have noticed if we'd just been taking single point measures, because the change is actually evidenced throughout the segment. So it was trying to show them, so in the keynote, I just told them about the technology. In this, I showed them how the technology can be useful in this certain application. And then within the presentation, the poster that I went on to do, it was all about the validation of the equipment that I was using. Now, I suppose for me, the most important aspect and the reason why I really wanted to go to the ISAK conference over anything else, any other conference that last year, was to be able to demonstrate to the collective where myself and the research group that I'm based within are heading with our intentions and try and present the most comprehensive comprehensive profile of what we do, not only to attract researchers in to work with us, but equally to kind of boost my profile within the society. So the society at the moment is very limited into the measurement methods that it uses. It tends to only be manual measurement methods, and with very little engagement into any innovation or research about how we can progress and increase accuracy any further, or even use it in any other way. I'm really keen to make sure that myself and the research group we're based in position ourselves to influence ISAK. And following conversations with other academics globally, I believe the best way for me to do this is to get on the ISAK working group committee. So I have to get nominated, and I have to get voted in. Now this year I managed to get nominated, wasn't voted in because people don't know who I am, because I'm just Alice Bullas in Sheffield Hallam, and I've not got a big enough profile for people to know me, know that I'm credible, know that I'm trustworthy enough for them to vote for me to be on the board. So part of this conference was to really increase my profile and increase that of sports engineering at Hallam and the morphology group at the AWRC, so that when it comes to being the nominations in 4 years' time, people know me because I've attended these conferences, I've presented almost excessively at these conferences, so they know my face, they know that I'm trustworthy, they know the research I do and what I'm intending on helping ISAK achieve. And hence why this conference, a lot of it was about networking and trying to influence the society. It went quite well, actually. I won the Best Young Investigator Award, which was very nice. I was able to build new relationships, as well as establish existing relationships with international partners for subsequent grant applications, which some have just gone in, which is really great, as well as gain a wider reputation, I suppose, for my work that has afforded me to be included in, hopefully, the organising committee for the next ISAK conference, as well as for the next ISAK accreditation course, where I can get my next level 3, which allows me to run courses through Hallam, which means we can accredit the sports courses that we run at Hallam through ISAK and give our students additional outcomes for their studies. It was also really nice. It was a really place to go. It was in Valencia. If nobody's ever been, it's a lovely place. Or it wasn't in Valencia, it was in Alicante. Really nice place. I'd never been before. I can't say I got to see a lot of it because the conference itself ran from 8 AM in the morning until 10 PM at night. So then I got home, got to bed, went to sleep and got up to go again. So I can't say I saw a lot of it, but it was very pretty, the bit I saw. But going to the conference achieved everything I wanted to achieve. So I suppose me wanting to present today was to say, if you are interested in this research or interested in this field, please get in contact. But equally, it was really useful planning tactically for the first time, I suppose, and going to a conference with a very set out plan as to what I wanted to achieve, not merely just my dissemination of information and knowledge, but kind of where that fits into my long-term research vision. That's it. Thank you. Did you want 2 questions at the end? Or?
Yeah, any questions?
How did you find that approaching people who have got well-established processes and methods, shaking up a little bit?
So I have been to ISAK conferences before and probably just sat there as a bit of a wallflower and let things happen around me. So I knew kind of who the bigwigs were. So what I tried to do is in each of my presentations, I picked different people. I kind of had a list of the, I would say is of the bigwigs that I knew would be attending and of what they were presenting, and had done a bit of background research on them, so that when I saw them in the audience, I appropriately gave examples that linked to their research. And because they were the bigwigs and everybody knew them, when I said them by name, everybody was like, oh yeah, we know their research. So it was like, oh, well, for Professor so-and-so, it would link very well into their volleyball analysis of their, this Barcelona protein. And why wouldn't you do this if you were tracking menstrual cycles in these women and you were having them in every single day to take blood markers? Why wouldn't you measures through body scanning? So it was I did have to do a bit of kind of preparation, but that seemed to kind of draw in the bigwigs. And because then it drew in the bigwigs, everybody else kind of followed and was very chatty, because it gave examples, I suppose, that other people were more familiar with maybe than myself. But kind of it looked, at least then, it looked as though they all had like validated and agreed with what I was saying, because they didn't disagree. Because they're not going to sit there and go, no, she's completely wrong, it will be useful. But they're like, oh yes, I see, it will be useful. And you're like, yes, okay. And that helped, because otherwise I think, like any conference, everybody's going with multiple agendas and they are sat there doing emails, as I have been in other conferences, and that way I named them by person and pulled their attention in. That seemed to work quite nicely, but I don't know, maybe I was being a bit cocky. I've not long since, I now have an 18-month-old. I have a little girl, and it was the first time, so this would have been in July, so she'd have not just been over 1. It was the first time I'd left her for a couple of days completely on, not completely on her own. That would have been very, very neglectful. But with my partner and on his own with her. And I really felt if I was going to go and leave her for that period of time, I had to make it valuable. And that kind of, I suppose, probably put a little bit more fire at my bottom than it would have done normally, to go and be really kind of make this meaningful and make this as important as possible, because otherwise I may as well be home. But yes. Shona, do you have a question?
I was trying to find the bloody buttons because I was on Teams the last hour. I honestly think you probably did make an impact, because they would have shot you down if they thought you didn't have a decent idea. They're not shy about that, or at least they weren't in the past. So I think the fact that they didn't contradict you in person probably is a good sign, and you're not overinflating yourself.
Thanks, Shona. Girish?
Thanks, Alice. I think the moment has passed, because what I was going to say was, if there were any questions in the room, would you mind repeating them for the benefit of those of us attending online, because we can't hear what people in the room are saying. So if there are any other questions in the room, then would you mind just kind of repeating it? Thank you.
Lovely. And if that's all the questions, I will hand over.
Can I ask you just before?
Yeah.
I don't understand. This society, ISAK,
Yes.
do 3D body scanning manually, or
No.
they don't do at all?
They just do manual measurements. So they
Manual
provide
measurement.
standards as to how to use tape measures, stadiometers, calipers to measure the external form of the human body. But that they just do manual measurement So I was going to try and convince or kind of broach with them how ISAK can embrace 3D body scanning as a complementary method. Yeah, they're quite resistant, but I don't think they'll have any choice.
But isn't that because the body scanning used to be so expensive?
Yeah, completely sure enough, but it's just not now.
No, but they've not paid attention because they think it's too expensive, so they haven't noticed the price change. Yeah.
So I think, and that's why they're not going to be able to avoid it, because we now have it where it's in. Previously, their kind of big sell was that people can have tape measures really easily. They're really affordable. You can have them in here as prevalently as you could have them elsewhere in the world, and they would be set the same tape measures or be measuring in the same units. Whereas now we're at the point where this technology lies, and albeit, you know, with some limitations and some inaccuracies at the moment in mobile technology. Now, if we think that, I think it's some bizarre or high stat, like 87% of the world's population has some form of mobile telephone, and of that 60% of those, I think, I'm saying this off the top of my head, but it could be slightly wrong values, there's quite a lot of people have smartphones, then arguably you have more people walking around with potential 3D body scanners in their pocket than you do tape measures. So, you know, surely this is a technology worth at least engaging with and incorporating into the standards. Otherwise, we're going to get to the point where they're being used in practice and no standards are being used by ISAK to accommodate these. Now, standards exist within ISO and IEEE, but not for the applications that ISAK are looking in, which is mainly sport, dietetics, nutrition, health. And a lot of the ISO, IEEE standards are looking more at fashion, ergonomics, and there's obviously a translation, but you know, there needs to be that bridge met, and hopefully I will be that bridge.
It used to be used extensively in WHO evaluations of children's nutrition, so they were looking for small for size and stuff. So yeah, anything that would be affordable from that perspective.
Lovely. Lovely. Thank you very much. Okay.
Thank you very much, Alice. The second presentation is from Nik Kudiersky, and it is titled Feasibility of Aerobic Exercise in Training in acute strokes. Yes, in acute strokes. Change the title.
Okay. Thank you. Just the screen. Which file did you save it in?
It's on documents.
Yeah. Is it open already? Oh, okay, yeah.
Close,
Sorry.
close that one.
Yeah,
So
my bad. I got it.
Close Alice's one, so it's not on the computer.
There we go. Can everybody see that? Okay. Thumbs up, anyone, or just?
Yeah. Yes, Nick.
Yeah, that's great. Okay. Okay, so for those of you that don't know me, my name is Nik Kudiersky. I'm a PhD student based within SPARC, sometimes at the AWRC. And today I'm going to talk about my PhD journey entitled The Feasibility of Aerobic Exercise Training in Acute Stroke. So I'll start with some stats on the UK stroke burden. So there's over 117,000 strokes per year, and there are quite a lack of effective treatment options available. and it's got quite a high morbidity rate. So approximately 50% of people, only 50% of people will achieve functional independence at 12 months after stroke onset. This brings a huge societal cost of between 25 and 43 billion, which is attributed to high health and social care costs, as well as loss of productivity for both stroke survivors and informal carers. So the research phases consisted of a literature review of aerobic exercise in stroke, predominantly focused on preclinical or animal models of stroke. We then selected the optimal parameters, which brought about an improvement in stroke recovery, designed an intervention and study procedures. We then took that to a PPI panel at Graves Health and Sports Centre, which consisted of stroke survivors, their family members, clinicians, and academics. We made some tweaks to the design, and the next phases were to test the feasibility of the intervention, as well as the study procedures, and to conduct some mechanistic investigations. And this was all aligned with the Medical Research Council framework for developing and evaluating complex interventions. So it's noteworthy to highlight some of the key functional and biological changes that occur after a stroke. So in the first 24 hours, this is when the majority of cell death occurs, and this is followed by a surge in inflammation. As the inflammation begins to subside, there's a gradual improvement in neurological function. And there's also an upregulation in neuroplasticity, which is the brain's or the nervous system's ability to rewire itself around the damaged areas. And it's this upregulation of neuroplasticity within the first week, which is often referred to as a window of neuroplasticity. As I mentioned before, there's very limited treatment options available, and the most effective treatments are to remove the blood clot, which caused the stroke in the first place, and that can only be applied within the first 4 to 6 hours post-stroke. My research is focused on the acute and early subacute phases of stroke. We want to try and see if aerobic exercise can be implemented in this early window to enhance the recovery processes and take advantage of this window of neuroplasticity. So briefly touching on the preclinical evidence. When animals are, unfortunately, when a stroke is induced in rodents, and you give mice access to a running wheel and they exercise daily, so beginning about 2 days after stroke onset, for between 5, 7, and 14 days post-stroke, we see a significant reduction in brain damage, enhanced perfusion in the ischemic region, and an increased complexity of neural architecture accompanied by improvement in neurological function. So our aim is to try and translate this into clinical practice. And we went about this by conducting a feasibility study utilizing a specially designed exercise bike that's brought to the end of the hospital ward bed. And the way that it's designed, because it has the supports underneath the calves, even if someone has a significant weakness on one side of the body, they can still drive that leg round with a stronger leg, and they can still, which enables them to increase their heart rate and breathing rate, and take part in sustained aerobic exercise. So this is the end result, the exercise program that we designed with support from the PPI panel. So the blue phase represents passive motion, where the bike moves the legs for them with no active muscle exertion. The brown phase is a gradual warm-up. The pink represents 5-minute moderate intensity intervals interspersed with 1-minute passive rest periods. And as you can see, as the number of sessions increases, 5 minutes is added on, so there's a progressive design. We used the rating of perceived exertion to help guide exercise intensity. We chose this because it was practical, simple to use, could potentially be used by NHS staff at low cost. Something else that came out of the PPI event was that we'd need to use accessible information. So we used the Stroke Association guidelines, and this was to increase the inclusivity of the research to enroll people that have communication difficulties. So some key feasibility questions that we wanted to answer were, can we recruit enough people in the time frame? Is the intervention safe? Is it acceptable? Can we collect enough data? How does it interact with current practice? And can people complete the intervention? And if not, what are the barriers and how can we overcome those barriers? I've put this slide up just to highlight the complexity of the stroke pathway and to demonstrate how difficult it can be to recruit people for this type of intervention. So Sheffield is home to the hyperacute stroke unit for South Yorkshire, also known as a HASU. So people from Sheffield, Rotherham, Wakefield, Barnsley, or sometimes Chesterfield, if they have a stroke, they will have their emergency treatment at the hyperacute stroke unit. But to be able to deliver 5 exercise sessions, we needed to be very selective of who we recruited. Some people went straight home or straight to a care home. Some people went to a local rehabilitation centre. Others went and subsequently went home or to a care home. Others went back to Rotherham, Wakefield or Barnsley. So we had to, we could only choose people that would be admitted to the acute stroke ward in Sheffield. But even then it was difficult because some people were then transferred to the local rehab centre. So it was a really high turnover, fast paced, and we had to adjust the inclusion criteria so that we only recruited people that were likely to stay in Sheffield for at least a week. And in future, if we were to do this on a larger scale, we would definitely include the stroke, the secondary rehabilitation centre, so we could continue the intervention if people were discharged early. So we used the commuted block randomisation technique, and this was to ensure that we had an even balance of people with different levels of stroke severity. So it's an important prognostic factor. Someone with a more severe stroke is likely to have a poorer outcome. So to achieve that balance, we use this technique where essentially it creates 2 different randomization pathways, and also the block sizes were randomized. The reason for this is because as you get to the end of a block, it becomes very easy to predict what group the next person will be allocated to. So this minimized selection bias. So as I said, it was a very fast turnover, lots of people coming in, but also leaving the hospital quickly. So we recruited 30 participants in 13 months. Seems quite slow, but that was quite, that was in line with the literature. So I think we estimated that we would recruit between 1 and 2 participants per month. So we achieved our goal there. The problem with using the stroke severity as a stratification factor was that we didn't achieve an even age balance. So our intervention group was almost 13 years younger. So that's a key limitation when looking at any of our potential effect signals at the end of the study. So in terms of the intervention fidelity, so I delivered 55 exercise sessions, 20 were missed. So that was just over 70% of planned sessions completed. The main reason was early discharge, as I mentioned before. 1 person dropped out. We had 1 person with a pulmonary embolism, which wasn't related to the intervention. And 1 person didn't want to do the final session because of fatigue. But overall, we think it was quite a success in terms of intervention fidelity. So we had no adverse events associated with the intervention, which I think is an important finding, which I think is a key barrier to a lot of people. Well, stroke physiotherapists implementing aerobic exercise, it's often cited in observational sort of surveys that the safety profile is unknown. So I think this is quite a positive finding. In terms of acceptability, so everybody said the bike was comfortable to use. And here are some just some snippets, some quotes from the interviews that I conducted. after the intervention. So I won't read them all out, but in summary, it's using the bike was well received. Being on the stroke ward is a very lonely place, and it's quite uncertain about what's going to happen to people each day. So it provides a sense of structure and a sense of achievement, and some people felt really good after it. Now, looking at some of our 3-month outcomes. So this is the Barthel index. This is an independent score, or a disability score. So a score of 100 is fully independent, 0 is fully dependent. So our intervention group had a significantly better outcome at 3 months. But as I said before, they were 13 years younger. So it is something that we need to consider and adjust for in a future analysis. I also conducted some mechanistic studies. So one of which was looking at cerebral blood velocity using transcranial Doppler ultrasound. That's just a reminder in the corner. So this is a graph showing the one exercise session and the change in cerebral blood velocity. So the first bars represent the side of the brain that's not affected by the stroke, so the non-injured side. So we can see that during exercise, there is around a 10 to 15% increase in cerebral blood velocity, and this starts to taper off at about a third to halfway through the session. On the stroke affected side, there's a similar pattern, but at a smaller magnitude. And these are the heart rate values. So the red represents the mean heart rate. So although we've got a relatively stable heart rate during the exercise sessions, during the exercise bouts, there's a dissociation around about between the second and third bout. So what does this mean? So firstly, it's a positive finding showing that blood flow increases to the brain, which can potentially lead to beneficial changes such as the growth of new blood vessels or the clearance of inflammation. And also we've shown that people can exercise at a decent heart rate despite being bedbound and having significant loss of function on one side of the body. We also compared this to usual care, so a technique called early mobilization, which is essentially to get people out of bed early after a stroke and get them to stand up or to walk around. This is quite a controversial technique. Some disagree with it because it could lead to a reduction in blood flow to the brain, which could potentially exacerbate the injured area. Others think it's a positive, a beneficial intervention because it gets people doing functional activities as early as possible, linking back with that window of neuroplasticity. However, it's not been studied in the early, the changes in cerebral blood flow haven't been studied when standing up this early after a stroke. So that's what we did. And this is split into the stroke affected and non-stroke hemispheres. And what we found was that on the stroke affected side, when people stand up, there's a sustained reduction in cerebral blood velocity. So that was after 3 minutes of standing in that position, it stayed lower than baseline. However, on the non-stroke side, it rebounded back to the baseline level. So again, we've developed some knowledge in this area, which might have implications for future stroke rehabilitation or usual care physiotherapy techniques. We also looked at brain-derived neurotropic factor, which is a very small protein in the blood. As the name suggests, it does originate in the brain, and it is associated with the growth of neurons and the rewiring of the nervous system. It's also sourced in different parts of the body as well, so in the heart, the lungs, and skeletal muscle. Because we only had a limited budget, I had to be very selective when I took the blood samples. So ideally, I would have taken the blood samples after recruitment and then again after the intervention period. But I chose to compare the intervention group to the usual care group after that 7-day period, and then also to look at any changes in BDNF immediately after a single bout of exercise. So what I found was that the resting samples, there was a significant increase in BDNF in the intervention group, but there was no effect of no immediate effect of exercise on BDNF. So again, this provides some insight or some mechanistic insight into why this group may have recovered better than the control group. And then I just ran a correlation between the change in independence with this plasma BDNF. And there was a moderate positive correlation, but it does seem to be a bit driven by this outlier that had a massive increase in both BDNF and in neurological function. So in summary, aerobic exercise training in the acute phase of stroke is safe and acceptable. Cerebral blood velocity increases during exercise, but decreases when standing. And 3 to 5 sessions of aerobic exercise may increase BDNF as well as enhance post-stroke recovery. And lastly, just to say thank you to my supervisory team and Caroline Dalton for their support throughout this process. And thank you to Sheffield Hallam for funding this work through the Vice Chancellor Scholarship, and to the Sheffield BRC for their admin support setting up the trial. And thanks to all the therapy team at STH for helping make this work happen. And lastly, thank you to all the participants that gave up a lot of their time to take part, and to the PPI groups that helped refine the study at the beginning. Okay, so that's me done. Yeah, any questions? Yeah.
Quickly, where do you want to take the research next? So is this the last to do your PhD, or will it be another one? Or where would you want to take this?
Yeah. For anyone that didn't hear that, the question was, where do I want to take the PhD next, or what's the next study or the next project? So the aim is to try and firstly tweak any components of the study that didn't work well, such as only having it at one site. So if we could extend the intervention to a secondary rehab centre, then we think we'd get a lot more people recruited. And we'd like to do it on a larger scale and do a randomized controlled trial at multiple sites to try and see if it has an effect. So it was only a small sample size. So we've shown that it's feasible. The next stage is to see if it has a positive effect on recovery on a large scale in different settings as well.
And is that fall in your PhD time, or that you see postdoc?
I'll be looking to get a postdoctoral fellowship for that, whether that's, I think the key areas are either the NIHR Advanced Fellowship or the Stroke Association postdoctoral fellowship. But I might need to get some smaller sort of springboard, smaller grants in between that. Yeah. All right, thank you. See you later, Alice. Shona, you still have your hand up. I'm not sure if that's a new question.
No, it's a new question. I put my hand up. So it took me, I realized I hadn't been paying attention and didn't know what the comparison group did. And then at the end, you said it was usual care.
Yeah.
This was all done in one center. So is there some consistency in usual care? Because one of the big problems you have with multi-site studies is that usual care, in spite of what the official recommendations are, is often quite variable. So think about that in you're going to have to train usual care in your new comparison arm as well, control arm. But when I was looking at I forgot the acronym, the blood product, the blood byproduct, if you plot that against age, do you see anything? No, yeah, because to me, you've got two outliers in that, right? Which is the one at 80 and the one at 110, 108. To me, you've got two extreme outliers. If you left out, the correlation would actually be steeper. But what you wanted to actually do is fill in the gap,
Yeah.
right? Not do others. But I just wondered if there's a net, because we're all told that our brain gets more leaky as we get old, and I'm in that category. So is this the age effect? Are you getting the artifact of the fact that the cases were younger than the controls? That's the opposite effect, isn't it?
That's a really good point, and it's something that I'm looking to do next. I've got a list of analyses that I need to run. I mean, that's what I'll focus on next. So adjusting everything for age.
You just need to do multivariate analysis. It's not very complicated, but you can't put a lot of factors in because you only got 30 people. Yeah. Okay.
Thank you. That's good. Really good point. Is it Said or Said?
Saeed.
Saeed.
Thanks for the presentation, Nick. That sounds like a ton of work you've done to sort of get to that stage. A few questions that sort of came to mind from previous experience on similar studies. Who delivered this intervention in the end?
This was me. And
okay. Did you do any work with physiotherapists to see how they might actually implement it in future? Because I've done similar things, and us delivering it in the hospital, then talking to the nurses about, could you do this? Could the physios do this? When they're already very stretched and there's all the other problems, I get the feeling sometimes it might get pushed to the bottom of the pile unless you can show some excellent efficacy data first.
Yeah, that's a really good point. So I also interviewed staff members, which I could have included. I've not analysed the data yet, but I know from having those personal one-to-one conversations that the key barriers would be lack of time. So the intervention, when you take into account that you need to set up the bike, be there for the full duration, and then pack the bike away, it was highlighted that would be a key barrier. However, the solution to that was that if you could train other staff that, for example, therapy assistants or clinical support workers that have maybe, this is just an assumption, maybe they have a bit more time on the hands, or they could be allocated to that role. Because it is quite a simple intervention. There's not, but yeah, it is a really good point. And ultimately, there needs to be more funding available for more time hands-on with patients.
Mm-hmm.
The healthcare assistants might be more systematic too, because they don't have all the other knowledge interfering with their treatment regime.
Yeah,
that's
a good point as well. No, like potential bias from their training or experience.
Yeah, they override it.
I've just got one more question. It's a bit more mechanistic. Is that increase in cerebral vascular velocity meaningful in an exercise setting? So I know that you can get 50% plus increase in velocity. Is that fair to say, with more intense exercise? Is that likely to actually make a difference to function? I know there's a lot of work being done at the moment in places like Switzerland where they're looking at healthy individuals, but are we providing enough stimulus with those sorts of sessions?
I think it's really difficult to measure. So I think peak change in cerebral blood velocity is about 30%, and that is like as you said, a bit of a higher intensity just before the respiratory compensation point, or when people breathe really heavily. I think we've got to look at other parts of the body as well, and kind of infer that if there's an increase in shear stress and blood volume, that that could lead to angiogenesis. But at this point, it's difficult to say. If you look at the animal models, and they were utilizing moderate intensity, it's a bit more difficult to translate what that means. But there's an increase in perfusion or blood vessel network. So it does suggest that a 15% increase is better than, I suppose, no increase. But yeah, there does need to be a lot more work to really understand that. And I think brain imaging using like MRI perfusion would be a really interesting route to go down, but it's just very expensive.
Yeah. Cool.
And then,
Thanks.
Yeah, thanks for the question. Is there anyone else? I can't see any more hands up, so thank you everyone for your time. And if
Can I ask you one?
yeah,
Have you considered, I mean, this is not, the sample is not very big, obviously.
no,
Have you considered at all just examining as a split sample rather than
in what way? How would you split?
the severe strokes in one case and the more moderate one in the other?
Yeah. So the question was, because it's a small sample size, would you consider just splitting the analysis by stroke severity? So I used the cutoff point using the stroke severity scale of 15. We only had, because it was a small sample size, we only had, I think it was 2 or 3 people in the severe stroke category. So I don't think it would be possible to do that with such a small sample size, but definitely on a larger scale. Yeah, a good question. Thank you. Okay. Yeah, thanks everyone for listening, and hope you all have a nice Christmas break. I'll hand back over to Themis. Cheers.
Okay, thank you very much. This was the last seminar for this year. Thank you for your participation. We are going to resume activities again in January, the second half of January. And there are some slots still in the schedule that we have. If anybody is interested to participate and to present some research work, please let me know and we can arrange for the presentations. Until then, have a nice Christmas and a good break. Bye-bye.